Brilliant. Okay, so as already explained, I'm Jenny Clark, and I am working in the network development team at Healthwatch England. I've also previously been a local Healthwatch director as well, and I joined Healthwatch England about a year ago as the Deputy Head of Engagement and Sustainability, supporting local Healthwatch with their engagement methodology, and also supporting with financial sustainability. But in actual fact, what I've spent most of the last year doing is supporting local Healthwatch to be ready to collaborate together and with their integrated care system to make sure that people and communities have a say in the decisions that are being taken at a local level. The goals of the session today, really, I'm going to give you a kind of brief introduction to integrated care systems, how they work, and how they're changing the way that healthcare services are planned and delivered. And then just explore some of the ways that we can amplify patient voice at system level, and why it's so important that Healthwatch and the voluntary and community sector are champions for public involvement. Now, I'm going to do that with plenty of caveats, because I'm not a policy person. I don't work in our policy team, but I've interacted with sort of national teams around the sort of system transformation. And also the systems are different by design in every area. So what's right in one place isn't going to necessarily be right in another place as well. And also, this still early days. Go live date was the 1st of July. So we're still trying to kind of work this sort of stuff through. Now, I'm not going to, because it's too long, it's a 5-minute video, I'm not going to show you this video, but the King's Fund has updated its amazing animation on how the health and care system works and how it's changing. So there's a link here in the slides, which will be shared later, I'm sure, which you can watch, which sort of explains in very simple terms what the integrated care systems are. But needless to say, that the sort of transformation of the of our health and care system is about bringing together services to deliver integrated health and care. And so you can see here through this diagram on the right that local authorities and integrated care boards together are delivering. And what I like to think about this on the left, the diagram here is that actually this could be about an infrastructure for listening. How do integrated care boards and local authorities make sure that voices are heard all the way up to Parliament? And you can see there in the middle is an arm's length body. Healthwatch England has a role in that, as well as local Healthwatch. So in the development of the integrated care systems, they have been given 4 main aims. The first is improving outcomes in population health and healthcare, and that should be delivered through integrated care pathways. They also have been given a role, importantly, in tackling inequalities in outcomes, in health outcomes, health experience and access. So not necessarily here focusing on the social determinants of health inequalities, but looking at inequalities in the system, the outcomes, the experience and the access to health and care. Enhancing productivity and value for money. So there's always a sort of financial element to that, but also to helping the NHS to support the broader social and economic development. So that's kind of social determinant stuff. So we're not going to say that they can tackle that alone, but they should be contributing to that. So you will have seen this diagram, I think. Sorry, I can hear feedback. Would somebody mind muting, if that's all right? So you might have seen this diagram. This is a diagram developed by the King's Fund that tries to explain the integrated care systems. So I'm going to try and do that really quickly and at a very light touch level. So NHS England performance managers and supports the NHS bodies working through the integrated care systems at a national level. They can't control the decisions that they take largely, but they are there to support them and assure that quality is good. And the Care Quality Commission has been given a duty to independently review and rate the integrated care system. So in effect, what that means is through an assurance process, they will almost like inspect the integrated care systems. And the Care Quality Commission are thinking about what the role for people in communities is in that, and how do they work with the Healthwatch network, and that's all still being explored. That framework won't be in place until April next year. So the Health and Care Act, which was passed in July 2022, has set out two sort of statutory bodies, one which is the Integrated Care Board, and you will have seen that the Integrated Care Board started in July. They've developed constitutions which underpins their membership and how they will operate, and they receive the NHS budget for an integrated care system patch, which, you know, at its most complex would contain sort of up to sort of 13, 14 local authorities. As its most simple would be coterminous, so it just has one local authority within its footprint. Now they get the budget and they make decisions about how to allocate that budget and how to delegate their authority to the other entities that sit underneath it. And they're supposed to do that by producing a sort of 5-year forward plan for how health services will be delivered. They have independent chairs and lots of non-exec directors that sit at a national level, and the integrated care boards are supposed to, in their constitution, set out how they will involve the voices of people and communities in their decision making and how they will resource that. So your constitution should say how that's going to happen. In real terms, lots of them don't, and that's one of the things that we've been talking to NHS England about. The Integrated Care Board works together with the Integrated Care Partnership, and that's supposed to bring together in a partnership representatives from the local authorities, the Integrated Care Boards, Healthwatch and other key partners. And the role really is to kind of, on an operational level, meet the wider health and public health and social care needs in an integrated way. And what they've been required to do is to set out their intentions in an integrated care strategy, which has to be published by December of this year. And that strategy was supposed to be developed in consultation with people and communities. We're hearing different views about how that's happening, but that was what the intention was. And then there are partnership and delivery structures. So at a system level, there have been developments of provider collaboratives. So this is bringing together the NHS trusts, acute specialist trusts, mental health trusts, as well as the voluntary and community sector organisations and the independent or private sector, bringing them together so that they can work together as providers. We know a lot less actually about how the provider collaboratives are working in practice, and that's something that and how they're involving the views of people and communities, and that's something that we're trying to get a greater steer on at a national level. At a place-based level, so this is the traditional footprints for local Healthwatch and often for advocacy contracts and the voluntary and community sector sort of collaborations, where Healthwatch and the voluntary and community sector have had a seat on health and wellbeing boards. They've been involved in the development of the health and wellbeing strategies, and they've been involved in sort of JSNA production, the Joint Strategic Needs Assessment, which sets out what needs there are at a place-based level. And some of those health and wellbeing boards are still going to operate, and some of them are going to operate alongside what's called a place-based partnership. So that place-based partnership can include integrated care board members, local authorities, voluntary and community sector, Healthwatch and primary care stakeholders. And that might be the same as the Health and Wellbeing Board. They might have just wrapped that up together, or it might be separate to that and running alongside it. And then at a neighbourhood, you have your primary care networks, which are sort of partnerships really mostly between general practice and community and dentistry and opticians, but often include the voluntary and community sector as well, to work much more at a neighbourhood level and tailor the delivery to meet very, very local needs. What I have added in a pink box is also that there are system quality boards, and they do what they say they should do. They look at the quality of the services that are being delivered, and those system quality boards sort of sit alongside the integrated care boards and often have a seat for local Healthwatch. I'm going to just touch on this because I think, again, this is something that you need to go and read a bit more on. There's a bunch, a whole host of guidance that's been published for integrated care boards and partnerships. And if there was one piece that I would suggest you read, it's the statutory guidance on working with partnerships, working in partnership with people and communities. It's statutory, which means that that the integrated care boards and partnerships have to follow it. Some of the guidance is advisory, but this is a statutory piece, and it sets out 10 principles of involvement, which in broad terms says that people and communities should have an opportunity to be involved at all levels within an integrated care system, from the integrated care board right down to individual decisions that are taken about services. And it sort of sets out those principles, and often what you'll find is integrated care boards using those principles in their own documents to state how they're going to do this. It also sets out responsibilities, so for the integrated care board, the integrated care partnership, the place-based partnerships, and those provider collaboratives. So I would suggest that you read them through, but broadly it's about how do those entities within the integrated care systems involve people and communities in their decision making. One of the things that I would kind of call your attention to, though, is that it's the integrated care board that must make assurance that people and communities are being involved in decision makings at all of the other levels. So they're involved in kind of holding the system to account at a general level for the principles being implemented. So what does that really mean? I mean, that this is all very complicated systems. And actually, I think if you spoke to someone on an integrated care board and said, how does it work? Where's a decision taken on primary care, or where's a decision taken on mental health? They wouldn't necessarily be able to answer that quite yet. So what I'm going to talk you through is some sort of hints and tips for getting yourself ready to ensure that people in your community are able to kind of influence the system. So the first thing is to know your system, because I can't sit here and tell you how your system makes decisions and how best to influence them, because it's a permissive structure, so they were allowed to develop in the way that they wanted to. So to get to know your system, you have to do your homework. So this is something that you would potentially want to do collaboratively with other Healthwatch within your integrated care system, and also potentially with the voluntary and community sector alliances that have been developed in many integrated care systems. So the first thing to look at is your integrated care board constitution and their governance handbook, and ask them the question as well: how are you assuring yourself that the views of people and communities are being considered when you're making your decisions? Because that's what they were supposed to set out. And if there isn't a Healthwatch representative on the integrated care board, who is taking the lead for that assurance role? So that would be your first piece of homework. Who's responsible, and how have they set out in their constitution they're going to do that? The people and communities engagement plans were developed and have all been published, and I've given you a link to one. This is the West Yorkshire and Harrogate that you could have a little look at. You should be able to find your people and communities engagement plan and look at how it says it's going to listen to people and communities. Now, we've had a look at the plans, and some of them are cut and paste from the clinical care and clinical commissioning groups engagement plans, and some some of them are much more detailed. Have a look at yours and see. I would hope that at least if you're working in a Healthwatch, you would have been involved in the development of the plan, but that isn't necessarily a given. So have a look. That should set out their intentions. The integrated care strategy are being developed now. As I mentioned, I would hope also that Healthwatch, at least, and the voluntary and community sector would be involved in developing those plans currently. But if you haven't seen a draft of it, or you haven't seen the plan for a plan, then I would ask for that and read through that and see how you can influence that. The joint forward plans are something that you need to be aware of. So the 5-year plans that the integrated care boards are supposed to develop in response to the integrated care strategies are due to be published in 2023. And thereafter, they will be publishing annual forward plans, which are like what clinical commissioning groups used to call their commissioning intentions. So that sort of sets out what decisions they're going to take on an annual basis. How are they going to change the way they're spending money? The integrated care boards have also set out what's called a scheme of reservation and delegation. So this is basically like, who gets to make the decisions? Is it at the place level with the place-based partnership? Is it an integrated care partnership? Is it the provider collaboratives? Where are decisions being taken? And where are they putting their pots of money? Because they're not going to necessarily hold it all at a central level. They're probably going to delegate some of that spend down to different decision-making bodies. And in order to know how people and communities can influence a decision, you need to know where it's being made. So I've put a link to a scheme of reservation and delegation. They're complicated and they're really difficult to kind of plough your way through, but you can pick some of the decisions out. The functions and decision map is supposed to make that more simple, but often they haven't been published yet. So that's something to keep an eye on. The place-based level is something that you're much more familiar with. So the health and well-being strategy and the joint strategic needs assessments are still being published at a place-based level, and that's something you should be aware of. And think about, how do those place priorities get reflected in the system-wide plan? And obviously within your provider collaboratives as a local Healthwatch, you would have an eye on the quality accounts and any strategic plans that are coming out. How can you influence that? So what does it mean for how to create influence? Well, one of the ways that that's built into the system is through representation, and often this is Healthwatch or the voluntary community sector having a seat at various different boards and committees. So at an integrated care board level, we talked before about who is it in the integrated care board that makes sure that people and communities' views are being listened to, being heard, and that that's being done in a meaningful way. And in about a quarter of integrated care boards have a Healthwatch rep, and some of those Healthwatch representatives have been selected through a sort of formal selections process. Others have been decided upon by Healthwatch collaboratives coming together to nominate someone, and some of them are rotating them around. But that means that there are three quarters of the integrated care boards that don't have a Healthwatch rep. So who is it? Who's your non-exec director? That's your point of contact, and how can they ensure that they're representing that agenda? Integrated care partnerships are all supposed to have a voluntary and community sector or Healthwatch rep, and they are a little bit further behind the integrated care boards, but certainly the development of the strategy will strengthen them and how they work together. So by having a representative there, that's an important way to get people's views listened to and to get them responded to and action taken on their behalf. I guess one of the challenges around representation at integrated care partnership level is that the needs of place-based communities are so different. So if you have just one representative on an integrated care partnership, it's important to make sure that they are tooled up to be an effective rep by having the access to the insight across the patch and not just the area that they work in, not just the place that they work in. And it's still important to be represented at place, and sometimes you hear integrated care boards saying, well, place is prime, you know, and that they're planning to delegate responsibilities down to place. So there will still be, the place-based partnerships will still have power and control, and I imagine that that spending power will relate particularly to primary care. So you still need to be represented at your place-based partnerships and your health and wellbeing boards, and also the health and overview and scrutiny committees, where there's an opportunity for sort of political, democratically elected representatives to hold the system to account as well. And often those you know, those councillors that sit there are good allies for the voluntary sector, and Healthwatch in their role of holding system to account for listening to people. The system quality boards are interesting in that many of them are trying to look at how they involve the views of people with lived experience directly on the board, but they're also looking at how Healthwatch Insight can help them to get an understanding, a more real-time understanding of what issues people are facing. So they do look at complaints data and kind of events that shouldn't happen and particular incidents, but they will also take into account trends that you're hearing and think about how they need to improve system quality as a result. There is a regional quality board that fits into, and often because we're focused so much on place at Healthwatch and now at integrated care system level, regional is sort of a bit of a missing link. So, you know, there is an opportunity to work at a regional level with your NHS England team to make sure that they're listening to what's happening at a system quality board level. But there are many spin-offs of all of these different boards and committees and working parties and groups that sit all underneath them, and you could spend all of your time in meetings. So I would suggest that, you know, within your integrated care system, the Healthwatch sit together and think about which ones you can most add value to, and it might be that you have a temporary membership of something so that you can influence a particular decision that's a priority for the Healthwatch or the voluntary sector in your area, because it's a priority for people. So one of the things that we have been talking to Healthwatch about is that if you want to influence your system, you can't necessarily go just with place-based information. So Healthwatch particularly are, you know, systematically gathering the views and experiences of people using health and care at place and trying to influence decision making at place, and that's not going to change. But if you want to influence decisions that are being taken at a system-wide level, which have far-reaching consequences for large numbers of people, then you need to be able to present the views and experiences of people and communities across the system, which means that Healthwatch and the voluntary community sector need to collaborate in a different way to collate that insight, so that you're not providing a sort of siloed, place-based view of what people's experiences are, that you're able to identify trends and outliers for people who are experiencing inequality in a different way to the system, so that it's collated, and also looking at coming together to develop joint sets of recommendations. There's no good presenting kind of 10 different reports on crisis mental health services with 10 different sets of asks, because that's very difficult for the integrated care boards to respond to, and you're much less likely to create influence. So have a think about what's the best way to collate insight across patch, and what's the best way to co-design, ideally with people with lived experience, the recommendations that you're going to make to systems in a way which will enable them to be much easier to digest and respond to. So there's loads of good practice that's starting to emerge already, and I'm just going to touch on a few examples, and there's a link here to some case studies that we developed. And I will caveat this with, like, these are emerging good practice. Actually, now this was pre-July, some of this work as well, so, you know, there's going to be much more coming to the fore now. But the first one is in Southeast London, where the local Healthwatch have come together to develop a sort of collaboration and they have employed a coordinator who does all of their representation work. It's hosted by one of the organisations, but it services all of the local Healthwatch in the area, and that means that they're able to sort of collate insight and present it back to the system, because they've got that one person who sits system wide. In North East London, they actually won an award for this, a HSJ award. Healthwatch have been leading on collating insight across different places, including the Healthwatch, the voluntary sector, and some external sources like NHS Opinion, to present that back to the system. So they're able to kind of give them an overarching set of data, which is really through an insight hub, which is really influential. In West Yorkshire and Harrogate, they've been really central to building the infrastructure of listening. So they're developing kind of community-based forums with representation of people who face inequalities. So moving away from the patient participation groups, which tend to be sort of older, retired people, towards really targeting communities that face inequalities, so that there's a forum for the integrated care boards and partnerships to check back in on their decision making. In Greater Manchester, the 10 local Healthwatch have come together and developed a strategy which has set out a set of common priorities, and they've defined how they're going to work together so that the system can better understand how they're going to work with their Healthwatch to involve the views of people and communities. In South Lancashire and Cumbria, the local Healthwatch came together at an ICS-wide level to carry out engagement using the same questions and the same methodology, being able to collate that insight on GP access and present that back to the system as a whole. And what we're starting to see is more and more areas commissioning local Healthwatch to do that ICS-wide engagement, and you know, that being much more influential than just bit pieces. In Mid and South Essex, the Healthwatch have worked with their integrated care system to get funding for a pilot of a Core 20 Plus Connectors project, working with people with lived experience of coming from areas of high deprivation or from particular groups that face health inequalities, and training up connectors to go out and work within their communities, so that people with lived experience are at the heart of change, and modelling a way for people with lived experience to be connected to decision makers. So there's some really interesting learning that will come from that. And I'm sure there's a whole host of other examples. Some of them I would be interested to hear from you as well. So these are my sort of top tips to help you to create influence within your integrated care system. Get to know your system and hold it to account for ensuring that it's implementing those 10 principles. Collaborate and don't compete within Healthwatch, but also with the voluntary and community sector. We all share an interest in making sure that people's views are heard and acted upon. So let's work together to make sure that that happens. But that means that you need to define your relationships. So developing little agreements or MOUs that prevent problems in collaborations coming down the line, to make sure that you're also understandable to your system, so that they invite you in and as an equal player around the table, and you're able to use that seat at the table in an effective way. Collect your insight and collate your insight and analyse your insight, so that you're presenting it back as a whole and not lots of different parts. And also, you know, be effective in your representation. Talk about what that really means. Is it truly representative of the system-wide views, or just the views of some communities? And it's okay if it does the latter, but just be clear about that. Make sure that you're making joint recommendations and reports, not providing 10 reports to one system and asking them to respond to all of them. And in all of this, our sector, whether it's an advocacy service, Healthwatch, or voluntary and community sector, we're great at participation of people with lived experience of inequality. We can reach communities that are seldom heard, and we need to ensure that the system values that. And all of this can't be done without resources. So we at Healthwatch England have been supporting local Healthwatch to make a resource ask from their integrated care boards to say, this isn't a change in our statutory duty, but it's a change of the burden depends on local Healthwatch, so you need to resource that, and many of the systems have done that.